All right. Well, hi, everybody. Welcome. I am Katie Westerneal, and I am a MECP2 Duplication Foundation board member, and I'm the mom to an affected 5-year-old, and his name's Charlie. And so on behalf of the board, we are really thrilled to have these 4 researchers with us today to kick off the Severity Scale project and talk about the research process, what's happening, and how families can be involved. So thank you to everyone for being here. I'm going to keep these biographies brief because we have a lot to learn today, but it's my honor to introduce these 4. So Dr. Bernard Suter is an assistant professor of pediatrics at Baylor College of Medicine and Texas Children's Hospital. He heads the MECP2 duplication clinic at Texas Children's Hospital and is the principal investigator of the IONIS biomarker study for MECP2 duplication syndrome and male Rett individuals. Dr. Devut Pehlevan is an assistant professor in the Department of Neurology at Baylor College of Medicine and a clinician and physician scientist in the Texas Children's Hospital Bluebird Circle Rett Center. He's a dual trained in child neurology and genetics and brings this knowledge together to work toward genetic modification treatments to MECP2 duplication syndrome and Rett syndrome. Dr. Sarika Peters is an associate professor of pediatrics and psychiatry and behavioral sciences at Vanderbilt University Medical Center and the Vanderbilt Kennedy Center. She's a psychologist with extensive experience in the detailed behavioral and neurophysiological characterization of neurogenetic disorders, including clinical research in Rett syndrome and MECP2 duplication syndrome. Dr. Jeffrey Newell is the director of the Vanderbilt Kennedy Center and the Annette Schaefer Eskin Chair of Pediatrics, Pharmacology, and Special Education at Vanderbilt University Medical Center. His clinical practice and research are focused on neurodevelopmental disorders with a genetic basis, especially Rett syndrome and related developmental encephalopathies due to alterations in MECP2 activity, such as MECP2 duplication syndrome. Whew, that is a lot of words. So we're going to move into the talks, and during them, please submit your questions in the Q&A box, and we'll have time for questions and answers at the end. And again, thanks to all of you for being here. So we're going to start off, we're going to go in the order of the introductions. So I think here we go. I'll turn it over.
Thank you. Thank you, Katie, for the nice introduction. So I'm Dr. Bernard Suter, and I just wanted to upfront introduce ongoing clinical studies in MECP2 duplication syndrome to you guys. And then I believe Dr. Peters, Dr. Pehlevan, and Dr. Newell will go into further detail for some of these studies. Next slide, please. So what is a really important point to keep in the back of your minds when we talk about these clinical studies is that all of these studies are being performed on a population that is a rare that constitutes a rare disorder. MECP2 duplication is a rare disorder. The FDA Orphan Drug Act defines a rare disease as a disease or condition that affects less than 200,000 people in the US, and that's certainly the case for MECP2 duplication syndrome. And what does that mean? Why is that important? In rare disorders, there is a much greater necessity for natural history / registry data, because these natural history registry studies really can potentially replace placebo arms of studies that would be performed in much larger populations, let's say in all people with asthma or something similar. And they also help to really us to understand the time course of symptoms and what unmet needs for treatment exist. Next slide, please. So why are we doing registry and severity scale clinical projects? What is the significance of those? Both really go hand in hand. We need a registry / natural history study that allows for questionnaires about key symptom domains of the disorder to be posted and answered, such that we can ultimately refine and validate and therefore develop a severity scale, which is instrumental for ultimately drug trials. This is really where families come in. The participation from families of individuals with these rare disorders is absolutely essential, so that we can validate the severity scale constructs, that we know that we are asking the right questions, that people are able to fill it out in the same way, that it is measuring clinical change with treatment as we expect. All of these aspects can only be validated if we both have the registry studies and severity scale development. Currently, we have begun severity scale development, and our current expectation is that it will take approximately 2 years, and Dr. Peters can probably very well go into more detail about that later on. The aim is really to be ready for use at around the time of the clinical upcoming clinical trial, the ASO Ionis trial. Next slide, please. And I forgot to mention that both the registry and the severity scale endeavor are being funded generously through the MECP2 Duplication Foundation. In addition to these two key endeavors, the registry and the severity scale creation, we also have embarked on a biomarker study, because there will be a need for objective biomarkers when you embark on the clinical trial. You probably are well aware that the Ionis biomarker study in MECP2 duplication syndrome and males with a Rett-like syndrome is ongoing. What is it measuring? It's looking for these biomarkers in order to distinguish these two conditions, because over-treatment may convert one condition, at least theoretically, convert one condition into the other, MECP2 duplication syndrome into the loss of function condition, male Rett syndrome, or the other way around. Currently, we're in the second cycle of assessments, and again, the participation part is expected to be concluded within approximately 2 years. Data analysis of these huge chunks of data may take some additional part. Next slide, please. Another important aspect are the genetic studies that are ongoing, and how do registry and natural history study relate to genetic studies? Well, MECP2 duplication syndrome actually has a fairly complex genetic picture underlying, and a variability in presentation, obviously. In the registry/natural history data is essential for us to finally determine the clinical picture. And the genetic studies in conjunction with that are important to determine what part of the clinical variability is maybe due to this complex underlying genetic picture. Also, the genetic studies may potentially help guide future treatment. Next slide, please. Here, just 2 slides that I have borrowed from my partner in crime, my colleague, Dr. Pilavan, exemplifying that when you talk about MECP2 duplication, you have some individuals with simple duplications of the MECP2 gene. Then you have some individuals with complex duplications where maybe a triplication is part of the duplication. And you have some rare individuals purely with a threefold amount of the MECP2 gene, a triplication. Next slide, please. And what we, for instance, learned through the registry is that the frequency of the these complex duplications is quite high in MECP2 duplication syndrome. Almost half of the patients, 45%, have a much more complex underlying genetic situation than a simple duplication. Next slide, please. So as I already said, genetic studies looking into this will help pinpoint the drivers of clinical variability and also help us potentially stratify ASO treatment or other genetic treatment. Next slide. But my take-home point at the end of all of this is that MECP2 duplication syndrome is really treatable. One avenue that, of course, is very, very high on the list of treatments for potential treatments for MECP2 duplication syndrome is the antisense oligonucleotide therapy. And what is exemplified on this slide, I don't know whether you can see my pointer, is that the way it works, at least schematically, is that we all obviously have the DNA in our bodies, and the DNA is converted to messenger, a construct called messenger RNA, which is really the instruction set to then build proteins from. Yeah. So what you see at the bottom is proteins being built, and the proteins are ultimately the building blocks of our cells. The DNA and the messenger RNA is the genetic construct in our cells, and the proteins are the actual building blocks of our cells. And antisense oligonucleotides bind to the instruction, the messenger RNA, the middle set, and when they bind, the whole bound complex gets degraded such that extra protein is not going to be built. Yeah. But obviously you have to be very well aware that you could put in too much antisense oligonucleotides and not build enough proteins, or put in too little antisense oligonucleotides and end up with the inverse situation. Next slide, please. And that this antisense oligonucleotide strategy is not just theoretical, has now been proven since 2015 to be quite successful in a mouse model of MECP2 duplication syndrome, initially in the Nature's paper by the lab of Dr. Huda Zoghbi in 2015. Next slide, please, where they showed that post-onset of symptom treatment with ASOs rescued multiple phenotypes of these mice, including the motor symptoms, learning and memory, synaptic plasticity, which important for learning and memory, and seizures and gene expression changes. And next slide, my final slide. And then it was replicated again in a second publication just this year, where they had constructed an even better mouse model of the human situation, where the mouse was carrying human MECP2 in its body rather than mouse MECP2, so that they could directly test that the antisense oligonucleotides that they were planning to use going forward, right, in humans, would also have that effect on human MECP2 in this mouse model. Before, there was one human copy and one mouse copy, and the mouse copy was, as it were, protected because the ASOs wouldn't have decreased the mouse copy. And with that, I will actually end up and leave time for the more in-depth discussions of the registry and the severity scale creation, and further studies driving this forward. Thank you very much.
Perfect, thank you. And yes, Dr. Pehlevan, you're up next.
Hi. And I would like to thank, before starting my talk, I would like to thank the foundation for organizing this event and getting us together with the families to explain you what we are doing in the MACB2 duplication field of research. So I'll briefly talk about the online registry in MACB2 duplication syndrome. As Dr. Suder mentioned, next slide, please. MACB2 duplication syndrome is a rare disease, right? So rare disease means we have only like hundreds of patients we are talking about, and that brings a lot of disadvantages to study disease. That's why we need to be unified and to have a stronger voice. And larger number means like stronger results for the studies, and also a stronger voice for us in general in the population. So for this purpose, we developed an online registry called this MACB2 duplication registry, basically to facilitate the communication with MACB2 duplication families and gather everyone under one umbrella. So our goals with this online registry are one, to expedite the studies towards clinical trial, because that will improve with this improved communications, and so that we can apply questionnaire studies that are more relevant to the families, that includes, let's say, gastrointestinal health problems or epilepsy or some others such as sleep. And also we are hoping that this will help us in this server will help us in communicating with the families in the process of clinical severity scale development that Dr. Peters will mention in her talk. So we are thankful to MACB2 Duplication Foundation again, because it is funded by MACB2 Duplication Foundation. And I would like to highlight that this is a HIPAA compliant registry. That means everything is secured as the medical information. So that is very important to conduct these studies. And also we have Dr. Ak, Muharrem Ak, in charge of this server. So he is communicating with the families if they need anything with the registry or there is any missing part. So he will be our corresponding person in this server. Next slide, please. So you can register at mds.nrihub.org. MDS stands for MACB2 duplication syndrome. .NRI is Neurology Research Institute hub.org. This is the web page when you enter to this link. And as you can see, there is a 5-minute tutorial about how to consent. But it is very easy. You just click on this red start consent icon, and then you will go forward. Next slide, please. And when you start the consent process, as you can see, we have a right upper corner. There's the Spanish version of this consent as well, that we wanted to reach and make this really a global effort when we are doing these studies. Next slide, please. And not only mds.nrihub.org, you can register through the foundation's webpage as well. MACB2 Duplication Foundation's webpage is macb2d.org on the left lower side of your screen. And when you scroll down, you will see at the bottom, there are like join the MDS registry circled in red. So you can register through that web page as well. Next slide, please. I wanted to give you, in general, where we stand with this registry by the numbers. So if you look at, and as expected, great majority of our registrants are from US. About 90 are from North America with Canada. And we have 5 registrants from South America. As I showed in my previous slide, we have the Spanish version. And given the size of the South American population, I think 5 is very small, just to highlight that part. So I think we need to more advertise in that continent. And in Europe, we have 34 registrants. As you can see, I cited a paper, I mentioned one paper in the right upper corner, the French MACB2 duplication cohort that is published in 2017. They are mentioning just from France, 59 subjects with MACB2 duplication syndrome. So just thinking about the entire Europe 34 is also far less from what we need to achieve. And also I would like to mention one thing. In Asia, I know that when we are communicating with few families in Japan, most of our Japanese friends are not speaking in English. That's why we are in the process of developing a Japanese version of the survey. Next slide, please. So since I am, or like in general, the foundation also, or some of the organizing family organizations get frequent emails whether they received or they were successful in registration. I wanted to say that if you registered successfully, you should get this NDS confirmation email, registry confirmation email. So if you receive this email, that means that you are successful and you don't need to do anything. However, I would like to say that if, like, we are asking families, or this process is asking to upload the genetic report, because we need to confirm if whether like your child has a duplication. We are asking, we may recontact you through the email you provided in the system to upload the genetic report if you didn't upload it. As I said, there are several families who think that they have McVitie duplication syndrome, but when we look at their genetic report, there may be a different diagnosis in there. And also you can download the consent form from this confirmation email at the bottom by clicking download your consent form here at the bottom of the email. So as I said, if you receive this email, you don't need to do anything else. Next slide, please. And I would like to mention also the meaningfulness survey that, like, thank you to many families, 126 people completed that. We conducted this like last September, October period, and around like 115 of them were eligible, and 11 of them were not eligible because they didn't have the McVitie duplication. And we had about 15 families whom we were waiting to confirm the genetic diagnosis. This was a very important study because we are hoping that your responses are based on your, like, how important those symptoms in your child to you, and how burdensome to you. That's why we picked those domains from the survey. And we will cross and analyze these with Dr. Peters' database, and we will pinpoint and build the structure of the clinical severity scale based on this survey. I know there was a question from some families whether this meaningfulness survey will continue. For now, it is inactive, but after our conversation with this like clinical severity development team, the speakers in today's talk, if we deem necessary, we can open the severity scale survey again, the meaningfulness surveys again. So just stay tuned on that as well. Next slide, please. So this is just a brief, like one section from the meaningfulness survey. We had about 100 questions, but this is the most core takeout message from that survey. As you can expect, epilepsy is the most important thing for the families, also most burdensome to families, and that should be in the severity scale. And other things that include are very important are in general developmental parameters such as the gross motor skills, communication skills, and they also fine motor skills. But in addition to those developmental skills, the constipation or the GI problems and the infection are important in McVitie duplication as well. Next slide, please. So I would like to mention one upcoming, hopefully, survey, another survey. We are planning to deliver this survey in the next 2 months. This survey, gastrointestinal health questionnaire, is developed by Dr. Motil, whom you may know, several of you may know. She has 30+ years experience in McVitie and RET-related disorders. And we are going to investigate several gastrointestinal problems, including the chewing, swallowing problems, the reflux, and the GI motility problems. And as we know from some conversations with the families, also in some questionnaires, GI problems can be more bothersome to some individuals with McVitie duplication than neurological problems. And as I showed in my previous slide, the GI problems can be is in top 5 for the meaningfulness to the families. So I highly encourage you to complete and also encourage other families to complete the survey when it comes out. Next slide, please. So again, in regards to this registry, please email me with my last name at bcm.edu or Dr. Ak, Muharrem.ak at bcm.edu in regards to this registry and the other survey studies. And thank you, and I'm done with my presentation.
Perfect. So Dr. Peters, you're up next to tell us more about the scales.
Yeah, so I am going to talk to you all about what we're going to do with all of this data. Next slide, please. Thank you. So I wanted to start off by talking about why do we need outcome measures? So we know that successful clinical trials are dependent on reliable and well-validated outcome measures that assess clinical severity. Any drug trial should show an objectively quantified improvement in the most important areas that are relevant to disease severity. So as Dr. Pehlivan was already mentioning, we have a lot of data, thanks to all of you and thanks to the foundation, now about those important areas that we need to be focusing on. A drug should obviously positively impact the quality of life of participants and their families. So it's one thing to be able to quantify improvement in terms of disease severity, but we also want that ideally to have an impact on your day-to-day quality of life and your child's day-to-day quality of life. So when we're thinking about outcome measures, we really have to know how are we going to measure how a child is or an adult is functioning right now relative to this syndrome. And also, how are we going to look at improvement during the course of a trial? So there will be multiple time points at which we will assess severity using these outcome measures. One would be prior to any treatment starting. And then we would continue measurements during the course of a trial. So the most important thing in all of this is our outcomes have to be measurable, meaning that they have to result in scores or numbers. What the goal for all of us is that these measures that we're creating could also be used in many other clinical studies of MECP2 duplication syndrome, which would result in a unified assessment. So no matter where your child or your adult is seen, you could be confident knowing that they're going to be assessed using the same outcome measure, regardless of where they go. Next slide, please. So there are two different kinds of measures that are needed. One would be, we use all these acronyms. One would be an observer-reported outcome measure that relies on the report of a parent or caregiver. That can be completed by you all prior to a study visit in the comfort of your home. A second is a clinician-focused measure, and what we are going to focus on is called a clinical global impression scale because it's commonly used in clinical trials all over the country. Next slide, please. So I'm going to first talk about the steps that are needed in the creation of a parent-caregiver reported outcome measure. So the most important thing to understand about this, for those of you who participated in the meaningfulness survey as part of the registry, or if you've participated in the natural history study in the past, we've asked you lots and lots of questions about early development and milestones. And those questions are very important in helping us characterize the natural course of MECP2 duplication syndrome, because as you all know, this is a fairly newly discovered rare disorder when we're talking about it. But for the purposes of a clinical trial, we want to ask questions that are focused on your child's functioning usually just over the last week or 2 weeks. We're not going to focus on early development because those are things that we can't change. That's already happened. It's already in the past. So to get a baseline, you'll be asked to complete questions about what's been happening across all of these different domains of importance over the last week or 2 weeks. In starting this process, as Dr. Palivon, Dr. Suter already mentioned, we actually have a lot of existing data, which we're going to use as a starting point. So we've got a lot of data from our natural history study, which Dr. Newell will go into a little bit more detail about next. And Dr. Palivon already mentioned the plethora of data that you all have helped collect through the registry. What we're going to do is pull this data together. We know that there are many common participants, meaning that there are families whose children participated in the natural history study who also completed the meaningfulness survey. So we're going to pull all of that together and then collaborate with Research Triangle International to help us statistically analyze this data. They have a lot of experience with instrument development, and they have also worked with a variety of rare diseases, including Fragile X syndrome, Angelman, and Rett syndrome. They know a lot about how to analyze items. The statistics will basically help us figure out what items kind of hang together, because we don't want this measure to be too long. We want it to be easy for you to complete because you're going to be doing it multiple times over the course of a trial. And we also want the items to be grouped together in a meaningful way. We want them to make sense. We want them to be easy and readable. And one of us should not have to be sitting there helping you interpret, now, what is this question asking? So that's the whole purpose of this statistics. Next slide, please. So related to that, we will field test new scale items and kind of get a sense first amongst us as clinical researchers, how does this sound? Does this scale make sense? And then take help from all of you on, okay, what do you think this item is asking? The outcome will result in a completed parent-reported outcome questionnaire, and then we will plan to use the registry to send that new version to parents and caregivers all over the world. And it can be completed remotely, can be completed in a HIPAA-compliant way, as Dr. Palivon already mentioned. So next slide. So now let me talk about the steps toward a clinician-reported outcome measure, which is basically a clinical scale. So based on responses from your input, as well as our own clinical impressions, you can see we've already started to make a list of broad domains of clinical importance. Dr. Palivon already mentioned some of that, and he already mentioned a little bit of what impacts families the most. The importance here, again, gets back to measurement. We want to be able to quantify those domains. So related to this, we plan to assemble a group of parent-caregiver stakeholders who will assist in defining and operationalizing these different symptom domains that are identified for a CGI scale. So we're going to develop what's called rating anchors for each domain. And basically that means, let's say a 1 would be very close to normal, while a score of 7 would reflect the most severe. And we would use those anchors across the different domains. So that will result in a rating of global severity, but then we would also have separate ratings to quantify improvement. So we'll have discussions of, well, how are we going to define improvement in this particular domain? And improvement is basically defined as what changes from one visit to the next visit. That is very important when we're talking about the efficacy of a drug, because you all can tell us, oh my gosh, well, I think it's helping, but we have to be able to prove to the FDA and other independent people who are looking at our data that, oh yes, I can see that, maybe this is the child who only had a pincer grasp at the beginning of this trial, and now they're able to pick up a spoon and bring it to their mouth. And that would be an example of a quantifiable improvement, let's say in a fine motor skills domain. Okay, next slide, please. Okay, and some of our longer term outcomes, when we're done with all of this, the goal will be for us to develop a training manual so that other clinicians and researchers around the world will be able to use this. We will also hopefully be able to film some video vignettes where we would be able to show example cases, and then the clinicians would talk you through scoring. So, you know, this particular child, in this case, we would assign a severity rating of a 4, and this is why. And then we'll also work to have a scoring guide out there for clinicians and researchers. Again, because the goal is not just for us to be able to use this, but we want people who are doing clinical studies around the world to be able to use the same kind of scale. So I'm going to turn it over now to Dr. Newell, who's going to talk more about the specific psychometrics that the FDA will be looking for.
I have to unmute. Thanks, and thank you all for the invitation and the opportunity to talk. I get to go last, and I was tasked with probably the most, technical and not as exciting part. So I'm going to try to define some of the terms I think that we've been hearing about as how the FDA looks at them and thinks about what makes a good measure. So let's go on to the next slide, please. So I think we've talked about it a lot, but some of the ways, the terms that the FDA uses, the outcome measures are like, what is the context of use? Okay, that's a big term. And so obviously for this point, our thing is we want for clinical trial. They want to know, are you going to use it in a clinical trial for a specific time disorder and time frame? It's going to be by the clinicians or the caregivers, like Dr. Peters was mentioning. And of course, as we've been talking about, is it really should reflect significant issues in the disorder you're studying, like the MECP2 duplication syndrome. And so we need to know what are the symptoms, problems that are important to people with the disorder and their caregivers. And we need things that are reliable and valid. I'm going to talk about what that means. We need to define what the sensitivity, and again, I'm going to talk about that. And of course, one of our problems right now is we don't have these measures. So the next slide, please. So, okay, so let's talk about, we talked a little bit about that defined context of use. So one of the things to think about, as this is being developed is this something that's going to be able to be applied to all people with MECP2 duplication syndrome? Or is it to a subset in terms of age or severity, or as they were alluding to in terms of different genetic composition? We got to think about what is the length of a trial that we might expect. Is it something that we want to see a change in 3 months or 6 months? How long will a trial be that you want to have a primary outcome to work? And again, it goes back to that, is it a caregiver or patient reported outcome measure or clinician reported? And we've outlined the idea of developing kind of both in parallel, at least some, because I think there's a lot of strength in having both. It should reflect these issues that are relevant. Let's go on that. Now I'm going to go to the next things. Next slide, please. So again, as we said, it should reflect these issues that are relevant to MECP2 duplication. So what are the problems? And we've heard a little bit earlier about from the registry from the Meaningfulness study. Next slide, please. So I'm going to tell you a little bit of some of the data from the natural history study, just really a high level, quick overview. This is something that's been started officially in 2003, officially enrolled in 2006. It originally was focused on Rett syndrome, Angelman, and Prader-Willi. This was before the identification of MECP2 duplication syndrome. So we had started enrolling people with MECP2 duplication syndrome in that original 9-year window, but then it expanded in 2014 till now. We've reorganized, so it's Rett syndrome, MECP2 duplication syndrome, and these related disorders, CDKL and FOXG1. And there's 14 sites across the country. Next slide, please. So we've been asking people in this last 8 years, in 7 years, what was their top concerns. At every visit, we would ask people with top concerns. So this is very similar to what was mentioned earlier about the meaningfulness. What do people care about? And we ask for the top concerns. And this is how the question was phrased. Next slide, please. And so this is, I'm comparing MECP2 duplication and classic Rett. This is in an order of the ranking of the top concerns. And there's a couple, and I've just shaded it. So the green is top and red is at the lowest end of that list. And what I think you can see, and as you heard earlier, that Davut was mentioning, actually, there's a lot of very similar things like, communication, balance, seizures, constipation, number 4, chewing and swallowing, number 5, and then frequent infections. So I think we've seen, there's a convergence on what people think are important. So that's great. I think we see that when these questions were asked, a lot of these people are the same, but at different times, we're still getting the same basic pattern. The other thing is that you actually see that some of the very top concerns are not that dissimilar from Rett syndrome. I mean, these are different disorders, we know, and it goes into, but there are overlaps in the concerns at the very top. But one of the things you can notice when you look at the Rett, that frequent infection in Rett syndrome, that was 18, but in MECP2 duplication is 6, which is exactly how we think, now that, that fits our clinical picture. We know that infections are a bigger issue in people who have MECP2 duplication syndrome than typical Rett syndrome. Next slide. So, but this is, the important thing is this helps us guide what are the symptoms and problems that are relevant, and then helps us guide what are the things that should be developed. And as we've heard already about the idea of having focus groups with caregivers and clinicians to sort of refine this and then determine how to best assess these. And then as we have questions that are focused on these, ask these stakeholders, is this the right way to ask the question? And are the levels appropriate, clinically meaningful differences, right? We want to build that into how you define it. Next slide. And then let's talk about, gets into the more detailed psychometrics, which is an important part when the FDA really thinks about it. So reliable and valid. So we've heard this terms a couple of times before. Next slide. So reliability. So reliability is how well a measure, that it measures a construct, as we'd say, consistently over time, people, and situations. So there's a couple different layers to this. One is something that's called a test-retest reliability. So the question is, if you gave this test to somebody and then gave it a day later or 2 days later, how similar are the results going to be? Is there so much variation in how it's scored or day-to-day variation? It may not be very useful. You'd like things to be on a short time scale, very consistent. Then you have things that are called inter-rater reliability. So if the same person rescores something at the exact same time, do they get the same scores? Or does the person, when they're rating it, change their scores when it's done at the same time? We're very, very close. And then the other is inter-rater reliability. So if 2 people scored the same person at the same time, will they get the same result? So all of these things are very important because you'd like these things to be reliable. You don't want them to change because it's a rater. You don't want to change it because it's how somebody felt it when they looked at it. And they don't want things to change so dramatically on day-to-day basis or day-to-week basis. And then there's part of it that goes kind of in this, is called internal consistency. So these scales, as Dr. Peters was alluding to, oftentimes have components that you might call subscales. It might be like, oh, this is a behavioral subscale, and this is a motor function subscale. And you'd like to know if the items within that are internally consistent, that if one item is similar to the other. They're not exactly the same, but they kind of hang together, as she said, and they're consistent. Next slide, please. Now, validity is to know how you're actually measuring what you think you're measuring. So, and there are different levels of this. The big part is this concept of construct validity, that when you're measuring something and you say it's measuring, let's say, anxiety or mood, that it really does measure that thing. And so there's a couple of ways that gets assessed. One is called convergent validity, which means that you can compare that to another measure of the same thing, and that they align. So classically, that would mean that you would measure, say, something you think that measures anxiety in MECP2 duplication syndrome, and you'd compare it to something that measures anxiety generally. And you'd say, yes, we see the same thing. They're consistent. That's hard, and we'll get to that with the challenges in MECP2 duplication syndrome of applying other measures because they're not readily applicable. But so one of the ways we think about it is that if you have the caregiver and the clinician both rating something that are in the same area, let's say motor function, and the clinician says something and the caregiver says something and they're consistent, we feel like, oh, that's converging. The other is divergent, which is important, interestingly, but basically that if you measure and you think this is measuring behavior and this is measuring motor function, and you compare it to other things that measure behavior and motor function, that the behavior things aren't correlating with the motor on a different scale, that they're divergent, that they really are, they measure one thing and not something else that's totally different. And so the other is with validity is, does the measure relate to other measures of severity? So, you know, and Dr. Peters alluded to this a little bit about like quality of life, you know, so if we say, oh, we think this measure, as the scores get higher, it's more severe, you know, we'd like to believe that we'd look at it something like quality of life measure, that it is also correlating with that. People who say this is my child is doing worse, has worse quality of life, that this measure also shows more severity. And the other would be, again, cross-referencing. If you have a clinical global impression of severity by a clinician and you're looking at a caregiver and the clinician says this is a very severe individual and the caregiver rates them at high, that again gives you this sense of validity. Next slide, please. So finally, let's talk about the sensitivity, the concept of sensitivity of a measure. Next slide, please. So sensitivity is very important when we start thinking, and it's probably one of the most challenging when we think about an outcome measure that we want to use in a clinical trial, because we want something that is going to reflect improvement. So it'll be able to see improvement, and it also that what it detects is actually a meaningful improvement. So some of the ways that we can do this is ask, does this measure that we've developed change over time, especially if we have a clinical impression that people with a disorder like MECP2 duplication become worse over time. We'd like to see that whatever we're assessing in this measure also is getting worse over time, because that would correlate with how we believe the disease progression occurs. We'd also like, since we also have a sense in MECP2 duplication that there are other factors like seizure worsening or more infections that may lead to overall severity, you'd like that measure also reflected that when you see worsening seizures or you see worsening infections, right? And then again, it goes back to this idea of what is you'd also like to know what is a normal amount of change that would be a natural variation within a time frame that's relevant to a clinical trial. So if you think a clinical trial is going to last 6 months, you'd like to have a sense in people who are not being treated just naturally, how much does it change naturally? Because that's a very important thing when we start thinking about designing a trial, because we'd like to see an improvement that would be beyond the normal change. And it may actually be that the normal change is that things get worse. And so part of it would be that you're not getting worse in that time interval. But either way, you'd just like to know what the normal progression in that time window is. So finally is the concept of clinically relevant change, so minimally clinically important difference. And this actually becomes a really big issue when you start talking about the FDA, because they might say, okay, yes, you can measure blank things, and you can tell me that it is statistically different. This at this time point and this time is statistically different, but they'll want to know, is that difference not just statistically different, but is it clinically meaningful? So it's helpful to try to have a sense of what it would be a score change that is clinically meaningful. And that's a very challenging thing to do. It's a little bit like a catch-22. The best way to do it is when you have a treatment that you know make things better, and you give people the treatment and you see the score change. But we need it to be able to show that things improve. So we're a little stuck. So there are a couple different ways that you can go about trying to assess this. One is what's called a distribution base. So what that means is that if we capture data from a significant number of people with MECP2 duplication on this measure, there'll be a distribution in of the severity. And then you can say, well, if you change more than a certain amount of that distribution, maybe that's significant. So that's one way of doing it. A stronger way of doing it is what's called an anchor base. So that would be based on comparing to a different measure of improvement. And again, this becomes a little bit circular. It's a little hard when you don't have a measure of improvement. Next slide, please. So we have these challenges in MECP2 duplication, as we've literally gone through a couple of times. We have a rare small population, and the very, very formal psychometric process, unfortunately, requires if you want to start totally from scratch, requires a significant number of samples that you capture. So typically, you need about 5 to 10 responses. So people filling out questions for every question that you're going to evaluate to really formally evaluate it. And most measures, an optimal size people think about, are about 30 to 50 questions. That both covers things well and also is something people will fill out, right? I mean, if it's much beyond that, you get burnout and people won't fill it out well. So when you do those numbers, if you really start from scratch, you're starting to talk about 150 to 500 people. So that's a lot of people. As we saw in the natural history study, we have 74, and as Davut was talking, there's like 140 something people. So we're a little challenged in this. But so the other is that we'd love to be able to compare to other validated measures, because that allows us to do the validation, but we have no other validated measures in MECP2 duplication syndrome. And one of the big challenges is that most measures that have been developed are targeted for verbal individuals, right? They are not targeted for the type of population that you see. And so they're very hard to apply to people who have MECP2 duplication. And then again, I mentioned this concept of anchoring for the severity, that we don't really have the optimal situation to anchor because it's a little circular. Next slide, please. So one of the things I think are some of the opportunities, though, that we have, so I don't want to leave it as a bleak picture, because I think that, one thing that I think, we can capitalize on a lot of the work that we have been doing in Rett syndrome from the natural history study. We have a much larger population in the natural history study that we've captured a long longitudinal data on, 1,200 people with Rett syndrome. And we've been able to do the really formal processes I've been measuring on some of the things in Rett syndrome. And so if we look at things and how we've structured them for Rett syndrome, we need far fewer people who have MECP2 duplication to see if they work, right? It's easier to take something that has been worked out, that the structure of it in one population, and see if it works in another population than it is starting from totally base scratch. And one of the things, the advantages, as I pointed out, is that a lot of the top concerns actually overlap between Rett syndrome and MECP2 duplication. We know they're different disorders and we know there's different issues, but at least some of the big things do overlap. And we are in the process of developing a caregiver reported outcome measure very formally in Rett syndrome. And we're at the sort of end of the final psychometrics, and we've got some really good results. So we have this longitudinal data on the 74 people with MECP2 duplication and natural history study. We are aligning the questions between that were captured in the natural history study and seeing how much they can align with what Davut was talking about in terms of the registry. And I think there actually is a lot of alignment, which will be very helpful, because then we can utilize the two data sets together. And one of the things is, as I keep talking about anchoring, is within the natural history study, we ask the caregivers at every visit to report on their improvement in the previous 6 months. And you can see how it's structured. You either have much improved, unchanged, worse, much worse. So that gives us an anchor. So if you have somebody who's been seen more than once and the family says, oh, they're much improved, now you can start looking at how much did the score of a proposed measure change in that between that. And that gives you a sense of, well, okay, if it changed 10 points and the family thinks they're much improved, maybe that gives us a sense, what is a clinically meaningful change? Next slide, please. Okay, so I think that this is not for me, but for the general overall.
Oh yeah, I think that was your last slide, unless you want to.
No, that's it. Thank you.
Okay, I thought so. Fantastic. Thank you so much. Wow. And you guys are like really phenomenal about time. Goodness. We couldn't have timed that better. We have a little bit of time. And I sort of want to wrap up with questions and answers, and also with the big question, and sort of like the overarching theme of today is, how can families get involved? Because that's the thing, is we're going to have all these, there are all these different ways to be involved. And the most important thing is that family participation, I mean, it's really going to be essential. Like, none of this works without families being really involved. So I think it would be really helpful to go through some of the different studies that we talked about and what is open for enrollment and what is coming soon in the future, because I think we've heard about a bunch of different things. So let me ask Sarah a question that you already looked at in the Q&A, but for people who didn't hear it, just so that we can be on here. So it's correct to say the natural history study isn't enrolling new patients right now.
That is correct. So
Okay.
our official end to the natural history study is tomorrow.
Oh, wow.
And
I guess people could enroll real fast and
yeah,
Bernard today.
tomorrow.
If you're going to clinic today, you should ask somebody about it. But if you're not going to clinic, clinic closes right in a minute. So if you're not going today, right.
What, and Dr. Newell can speak to this a little more if needed, but what the general plan is that all of the sites that are involved in the natural history study are going to continue to follow patients with MECP2 duplication syndrome at their respective sites. So the structure, so to speak, isn't going anywhere. Like, here at Vanderbilt, Dr. Newell and Dr. Fu are continuing to see patients in clinic. And obviously the data that's been collected in the natural history study will continue to be utilized. And that's what we're doing right now.
Excellent. So it's fair to say if somebody is coming to clinic that they could ask about it while they're there, but it's not like a separate something that they need to worry about contacting you and enrolling right away.
Right.
Right,
So
okay.
if you are already going to CHOP for clinic, or Colorado or Houston or here, and those were the places that you were already taking your child for natural history study visits, you could continue to be followed clinically in those same places.
Perfect. And for parents who have questions or want a recap of this, we are going to condense all of this and have this in a document for parents so that the things that we're talking about, just something like an FAQ, so it's easy to remember. And so the registry is open right now. And so like Dr. Pelavon said, you can go to there's 2 different ways to access that, either through the NRI site or through the MECP2D.org site. And then, Davut, can you talk a little bit about, there's also a genetics study where parents can mail in blood. Can you talk a little bit about that?
So yeah, thanks for giving me the opportunity to explain. So in addition to this registry and maybe the questionnaire studies, we are actively doing the genetic studies and the biomarker study. The biomarker study, it's a blood test. Is blood, the genetic and the biomarker studies require blood or sample. And genetic study, you can participate from any part of the world as long as you have a local provider who can draw blood for us. And we will cover the cost of shipment and the genetic studies, of course. But for the biomarker study, families need to travel to Houston because after blood is drawn, we need to process the blood right away. So we can't spend time on the shipment. That's why they need to travel. But the genetic studies, actively we are recruiting. And I think it's better for the families maybe to explain what kind of studies we are doing, and you can spread that first. We will send a kind of a document.
Yeah.
What Dr. Peters and Newell are offering, or the Baylor, we are as a one group now. We are going to offer in general. So as a summary, how they can participate and what is the purpose of the study.
Perfect. And so the meaningfulness, same thing, it's closed for right now. It may open again in the future, but so parents don't need to worry about that. Families don't need to worry about that right at this moment.
Exactly.
And then the gastrointestinal survey and the severity scale work, that's in the future. And that we will push out information about that when
Yeah.
it's ready and when we need new participants.
Yeah,
Yes?
gastro survey, like I would roughly estimate 2 months or so, because we are in the process of amending to Baylor IRB to get the
Mhm.
approval for the study. But the most important talk for today is like the topic is the severity scale.
Mhm.
That like we need to maybe run several tests with the families to get the test or retest those things if they are adverse. And so we will ask families to participate in those studies, probably through registry because it's easy to communicate and HIPAA compliant.
Yeah.
But that's for now, like not in the near horizon, maybe in the next few months or later. We'll like after our
Is
like,
that still in IRB, right? Dr. Peters?
Right.
Yeah.
So, yeah, we did, as it is submitted to the Vanderbilt IRB. They came back with some questions.
As they always do.
As they always do. And this is critical because they are considering that those parents and caregivers that we consult with will be formal participants in the research. So we will have a consent for you all to fill out. And that way you can self-select when the time comes that we need participation. And this will be again getting feedback about the importance of the domains and then how we establish the anchors for improvement and severity and things like that.
So for parents who aren't familiar with sort of the IRB and like the research process, so the project was identified, the foundation funded it, and then in all research, and it's even more critical in medical research, I think, you have to go through this process called IRB. So it's really getting permission from the university that you're doing the research safely, and it's to put, make sure that parents are going to be taken care of and that it's HIPAA compliant and that sort of all the I's are dotted and the T's are crossed in this process. So that is the part of the process that the severity scale is in right at this moment. And so like you heard about those focus groups and participating in surveys, that is going to come once there is permission to do that. So it takes a little while because there's a little bit of back and forth to make sure that all the safety protocols are in place and everything's just right for parents to go through the process.
So this is a question then, which I'm just throwing out because I'm sure it is a question, but so like as you said, with the registry, currently there aren't any active questionnaires, but can families still go on and register that they would be willing to be recontacted for future things? Because I think that's a very important thing for people to be doing, because like they were saying, probably a lot of this interaction is going to be through the registry. So if you register now, it's going to be great when more data needs to be collected.
Yes. Mm-hmm.
Yeah, we can't really stress that enough. And we say that a lot on our social media for the foundation, that yeah, if you haven't registered before, that's okay. Register now. People still need to register. And if we can grow that, like in Davut's talk, more is better in this regard in the registry. So yes, if you haven't done it before, do it today. You can go to our website. All right. Let's see. So I think this is a question, Bernard, for you about how does the severity scale fit in with the biomarker study?
Sure. Yeah, you really do need both of them to optimally, guide a clinical trial, because you will see changes once you are applying a drug that may not immediately affect a clinical picture, but may affect the underlying genetic landscape, right, as it were. And in order to detect changes that occur prior to clinical changes, you're really dependent on biomarkers that will tell you very early on if you're going in the right direction and if you're potentially overshooting with your therapy. is specifically for the ASO treatments, the antisense oligonucleotide treatments in those mouse model papers. What has been shown is that after giving the ASOs, there were genetic changes that were affected before any behavioral effects, and also those genetic changes were to some degree wore off over time, such that you need to detect whether you need to redose or readjust your treatment over time. And obviously, sorry, last part of that was the question about the severity scale. The severity scale, however, is absolutely instrumental to demonstrate that you clinically affect an individual in the way that you mean to affect the individual.
Perfect. All right, we had some questions in the chat, and we answered those. I did want to add to Michelle's question about Dr. Leonard's research in Australia that, right, even though it's not a part of these studies here, we are in contact with them, but it is two separate things. So even if you've registered with them, or if you've registered, we put it out there before the Eurodis registry, if you've done that one, this is separate. So you will have to go through this registry to participate in what we're talking about here today. So, and then let's see, another question that we have. So could a patient's level on the severity scale change over time?
Yes. So a patient's level could stay the same, improve, or get worse. And I want to make the distinction here that there's a global rating of severity, but then there's also an improvement rating. So a child may, and Dr. Newell can talk about this, you might show improvement but remain at the same severity rating. You might go up in both, or somebody could get worse. So what's important from the standpoint of a clinical trial, they will be looking at the improvement. So it's what are you at baseline, what's your rating of severity, and we will continue to rate that through a trial. But again, we're going to be quantifying improvement as well.
Excellent.
And I just add to it that, yeah, I mean, I think that I was sort of alluding to this, that, a clinical severity scale of some kind, let's say a caregiver reported, over longer periods of time, we would not expect it to be absolutely fixed. In fact, if it was completely fixed and never ever changed, it probably is not going to be very useful in a trial, right? Now, it may, get worse naturally, and that would be part of the thing to understand, because if it is naturally going up, what you'd like to see is that it doesn't go up like that, that it actually stays the same or gets better. Like that would be the goal of the trial. Like that's how you define what you think is a good endpoint. But actually on an individual level, some people may, and 6 months later, just happen to get better. And some people might happen to get worse just because of variations in their life, right? Their seizures got better, right? They got good medicines for their seizures, and 6 months later, their seizures better. Now maybe everything in their life is better. So we actually would hope that there is some dynamic aspect of these.
Excellent. All right, we have a question from Donna about biomarker blood tests. Can those be done in Montreal instead of coming to Houston?
Biomarker, as I said, we need to process the blood. That's why it cannot. But for the genetic studies, yeah, for sure, they can participate.
Right, so there's two different studies that involve blood right now, and one can be done in Montreal or wherever you are, and it can be mailed in, and one does have to be done in Houston. So if you happen to be in Houston, you should do that one. Yeah. But if you aren't, and you're far away, then yes, there is one genetic study that can be done from far away. And they should email you about that, right, Dr.
Yeah.
Pelovan?
Exactly.
Okay. And then a question from Michelle, and this is actually about trials. Do you intend to or have the capacity to enroll non-US residents in trials? So I don't know that that's I don't know who wants to take that one, but I think that's a question maybe for the drug company, but if anybody wants to tackle it.
Dr. Newell, you want to answer that?
I don't know what's going to happen with it, any future drug trials and MECP2 duplication syndrome, but typically, like for the trials that have happened in Rett syndrome, number one, you'd have to come to the U.S. and sometimes it's explicitly stated that you have to live in the U.S. And in fact, in the large trial that we're doing right now, it's actually you have to live in the 48 contiguous states of the U.S. So it's not even just the U.S. It's you have to actually, and that has to do with the frequencies of the visits and the travel, and concerns about taking, in that case, investigational products, so drug, like on the airplane and traveling across borders and stuff like that. So there's lots of logistics that go into that. And so the decision ultimately comes per trial. But a lot of times the trials do have, especially an early trial, especially if what we're talking about an ASO trial, which is going to be first in human and probably require a fair amount of safety monitoring and stuff. It'll probably be fairly intense in terms of both every activity that happens when you're at a thing and how frequently you come to the site for the visit. Typically, these kind of trials, especially at first, require a lot of monitoring because it needs to make sure they're safe, right? It needs to make sure they're safe. And so they don't want people who are flying in from Brazil for a week and then flying back and not going to be seen for a while because they don't know what might be happening. I'm just telling you how a lot of times this works.
Okay, but yeah, we're in this webinar, we're not talking about clinical trial yet. We're talking about clinical research and genetic research. Yeah.
And I can add that, like maybe in the later phases of the trials in general, they can expand out of states. But in general, the first studies are done locally in the US.
Well, and that's another webinar that we've talked about doing between the four of us that we've talked about, that is a separate webinar to talk about clinical trial and FDA and that pathway and what usually happens. So stay tuned. That could be coming soon. So I think we're good on questions. 15, I was just perfect timing. I just want to say thank you to all of you. This was so wonderful. It's always great to talk to you, and this was really perfect. And I feel like we have a lot of good information going forward about sort of the next things that are coming and where we really are going to need family participation. So here's our information. Email us, go to the website, especially if you haven't done the registry yet. And if you have any questions, you can be in contact with us, or you have emails from some of the researchers to be in contact with them about specific studies. So thank you all.
Thank you. Bye.
Yeah.
Thank you.